Okay, thank you. So I'm here today on behalf of Julian Archer, who sends his apologies that he wasn't able to make it at short notice, so I'm giving his presentation. And I'm going to talk about an evaluation of medical revalidation that's just kind of getting underway. It's going to run over the next 3 years. Julian's the PI, and the work's being carried out by a collaboration. This slide shows our UK-wide collaboration, which, as I said, is led by Julian and Plymouth, but also includes Professor Martin Marshall at UCL, Professor Kieran Walsh, who's here today, and also partners in Wales, Northern Ireland and Scotland. And the UK-wide nature of this is really important to the delivery of the study. It's going to aid our data collection. Some of the partner organisations are also going to share really important data with us. And we're also going to be doing analyses at kind of regional levels as well as nationally. So the collaboration has become known as Umbrella. So you'll see that on the slides throughout. So today I'm just really going to give a brief outline of the purpose of the evaluation, the work packages, the kind of data collection work and analysis that we're going to be doing over the next 2 to 3 years, and a very brief update about our progress so far. So this evaluation has been kind of at least 2 years in kind of the development phase. Some of you who were here last year might have seen Julian talk about an evaluatory framework for revalidation that the Camera Research Team was commissioned to develop by the GMC in 2013. The GMC at that point set out 6 aims for revalidation. There are 6 core regulatory aims. And from those we developed these 6 overarching research questions. The words in red highlighted in the slide really are just the keywords of each question. So our evaluation that we're now implementing is based around answering these 6 questions. And then each of these 6 are broken down into 4 or 5 further sort of detailed research questions. So there are in fact 30 research questions overall, but they're all around these 6 core areas, which is revalidation bringing all doctors into a governed system that assesses their fitness to practice on an ongoing basis, and is it doing that consistently? How is the requirement for all doctors to collect and reflect post-mortem information about their practice through appraisal working? Is engagement in revalidation promoting medical professionalism? Is it encouraging the adoption of the principles of good medical practice? Is revalidation working to identify potential concerns before they become safety issues or fitness to practice referrals? How are our roads fulfilling their function? And are patients being effectively and meaningfully engaged in revalidation? So, as part of this evaluation, as part of the conceptual design of the evaluation, we've conceptualised revalidation as a kind of a complex policy intervention, and we're using activity theory to kind of help us frame our analyses. So this is an example of an activity theory model. I'm not going to go through this in too much detail, but really it's just a way of kind of breaking down revalidation into its constituent elements and thinking about what and who is really involved in all of these different things. And when we're doing the analysis, we will map our findings back to this model and look at kind of the interactions within each element and the interactions between each element. So I'm going to move on now to talk really about the work packages, the data collection and analysis work we'll be doing. And in each of those, really, the kind of aim is to collect data and do analysis that we can then map back to this activity theory model. So there are 7 work packages that we'll be carrying out. Literature reviews, secondary analysis of existing data, national and strategic surveys, appraisal capture, interviews with key stakeholders, documentary analysis, and possibly root cause analysis of FTP documentation. Literature reviews, I'm going to skip over really quickly because of time pressure today. In Plymouth, we already kind of have reviews in play about appraisal and PCI, so we'll be kind of adding to those and building on them. Supporting information, we're going to try and do reviews around each of the 6 different types, categories of supporting information. We hope that most of those will be tertiary reviews where possible, so reviews of reviews. And we're also going to try and look in some way at responsible officer judgment making. The first major work package of kind of analysis work is secondary analysis of existing statistical data sets. We're going to extract data from the GMC about revalidation rates and deferral rates, and also about doctors' kind of personal and protected characteristics, their demographic characteristics really. Particularly in reference to that first question of, is revalidation bringing all doctors into a government system, and is it doing so consistently? So we want to look at if revalidation is being experienced in similar ways by different kind of demographic cohorts of doctors. We're also going to be using data from MARS, which is the Medical Appraisal and Revalidation System, I think, in Wales, and SOAR, the Scottish Online Appraisal Resource, I think, again. So they have data on appraisal rates and dates and appraisal deferrals, so they have kind of data at a more granular level. And we're hoping to link the data sets from Wales and Scotland with the GMC data sets to look at the relationship between, for example, appraisal deferrals or missed appraisals and later revalidation recommendations, again in reference to doctors' demographic characteristics. We might also use some data from NHS England, which is the bottom set, kind of annual audit data. That's collected at organisational level, so it's a slightly different type of data set, but we might use it for comparative purposes because there's no unified solution in England for collecting appraisal data. There's no kind of equivalent to Mars and SOAR. The next work package, we're going to do what's Julian's term national and strategic surveys. The first, which is currently in development, is going to be a census survey of all doctors practicing in the UK who are not trainees. So that's about, I think, 177,000 potential participants in that survey. There will be probably 5 sections to the survey. Core content for all doctors, which will be a section that asks them about their job role and the setting and the work that they do. Then there'll be a section asking them about their experiences of appraisal and revalidation and kind of collecting that supporting information. And then there'll be a section about their personal characteristics, their demography kind of thing. There'll also be additional sections for those doctors who identify themselves as also being appraisers and or ROs, responsible officers. And then we will also be doing a survey of kind of patient groups to ask them specifically about their experiences and understanding of patient feedback tools within revalidation and how those are functioning and how accessible they are and things like that. Out of the doctor's survey, we are hoping to recruit participants for further in-depth qualitative work. So at the end of that doctor's survey, they'll be asked if they consider taking part in some of the research work with us. And we hope to recruit 90 doctors and audio record their appraisals, both kind of this year and next year. And flexible approach to capture on Julian's slide means that we're actually going to ask them if they record them themselves using a smartphone or a dictaphone that we send them. If not, then we'll send a researcher out to set up the recording for them and kind of do it. We're going to thematically analyse those and then map them back, as I said, to the chat framework. We're also going to try to categorise levels of reflection within the appraisal meeting using an existing kind of categorisation tool developed by Food et al., I think. We're then going to do work package 5, which is the key stakeholder interviews. This would be us trying to interview all those doctors, hopefully, whose appraisals we've recorded, and also interview their appraiser as well, to ask them really about their experiences of and perceptions of that appraisal meeting, and also more broadly their revalidation experiences. And we'd also be seeking to interview some responsible officers and some GMC employer liaison advisors who are kind of a newish group of link people between the GMC and organisations. And again, those interviews would be thematically analysed and centrally mapped back to the activity theory model. The next work package is going to be documentary analysis of appraisal portfolios, so kind of the supporting information documents that doctors gather, and also the appraisal summaries, sometimes called Form 4, that the appraiser and repairee agree is the kind of output from the appraisal that goes on to the RO. This work we'd kind of only be able to do with doctors in Scotland and Wales because they have those kind of unified systems, and also because in those systems they've been gathering data both before and after the introduction of revalidation. This analysis would be based on existing quality assurance models used in Wales and Scotland, and then we triangulate the data with the findings from the interviews with those doctors, their appraiser, and also the recording of their appraisal meeting. And really the aim through these kind of 3 linked work packages is to try to get a really in-depth understanding of how information about an individual's medical practice flows kind of from them and what they collect into their appraisal meeting. Does the discussion in that appraisal meeting reflect what they've collected? Do they kind of privilege or focus on particular aspects of the supporting information? And how then is it summarised and passed on to the RO? So we're really trying to find how information flows from the individual about their practice through this system to the regulator. The 7th and final work package is aspirational, which means we don't know yet quite if we'll be able to achieve this. What we would like to do here is to conduct a kind of root cause analysis of appraisal documents in cases where doctors have been referred to fitness to practice procedures. So that would mean kind of identifying doctors who are, perhaps who have been referred to the fitness to practice procedure, particularly by, it says on here PAPC, that means person acting in a public capacity. But we'd be specifically interested in doctors referred by their employer or perhaps by an RO or an ELA. And we would try to then access their appraisal documentation from sort of the previous 5 years, hopefully, and look at was there anything within those appraisals and within the appraisal summaries particularly that might have pointed to the issues that later arose. So it goes back to that research question of sort of how revalidation identify concerns earlier. This again we'd only be able to do with doctors in Scotland and Wales because again of that existing data. But there are significant issues we recognise around the ethics of doing this. Doctors referred to fitness to practice procedures are kind of a vulnerable group. And also simply issues of recruiting people to take part in this and consenting to give us that access. So we will keep discussing whether that's going to happen as we kind of move through the study. So that, in summary, is the 7 work packages. And our progress so far, well, we're in the very, very early stages, really. The ethics submission has gone in and we're awaiting approval and feedback before we can start doing any of the real data collection work. We're hoping to have that by the end of this month. The secondary data work we're hoping to start soon. We're in discussions to finalise the extraction of that data with the GMC and with the Wales Deanery and NHS Education for Scotland. Because we're going to try and link all those data sets, it's very complicated around data protection and things like that, but we're hoping that will all be in our hands soon so we can start to work there. The survey we are hoping to send out in late May, so it will probably run between late May and early July, be open for about 6 weeks. Content's currently kind of in the final stages of development, we'll pilot it shortly, and we'll also kind of accompany the launch of that, be advertising to the profession. And as part of that, you can follow us on Twitter, should you be interested, and we also have a website which is due to be launched very soon. It might be launched today, apparently, but I'm not quite sure if that's actually happened. That'll be umbrella-revalidation. So that really was just to give you an introduction to the work that we're going to be doing, and we very much hope to be back here at events like this presenting some findings next year and the year after. Thank you.
Great, thank you. Next we have a presentation by Suzanne Nunn, who's also from Peninsula Medical School. And we're talking about the McDonald'sization of medical appraisal.
I suppose in a sense perhaps Marie's work package might answer this question for me ultimately, but I don't know. So this paper, this paper then draws on some recently completed research which was funded by the Health Foundation and was entitled Revalidation in Practice. And what that research did was it sought to explore the early operationalisation of revalidation. So the primary data was generated by videoing medical appraisals and transcribing 24 semi-structured interviews with those who were actively involved across primary, secondary and community care down in Devon and Cornwall. Now this yielded a very rich set of data, as you can imagine, and we're just beginning to kind of address this using different paradigms through which to critique the processes and discourses pertaining to revalidation that we have identified through the data. Now, appraisal is at the very heart of revalidation, and participants in the research overwhelmingly considered annual appraisal to be an extremely valuable formative process. However, as appraisal becomes linked to revalidation, many of them expressed concerns that revalidation could become a driver for appraisal and the nature of appraisal would change as a result. In a typical evaluation, this appraiser, he said, it depends on how creative and human the appraisers are going to be. If they're going to be box-ticking bureaucrats, then yes, we'd have lost a valuable method of formative education. And this was echoed here by another appraisee. I think the direction is towards tick-boxing, and I feel really sad about that, because I was someone who was appraised and did appraisal, and I thought that this was a really useful process. We observed, and doctors recognised, that currently there was a significant variety in the form and content of appraisal, even although the elements are determined by the GMC. The doctor's main concern leading on from this was the potential for any rationalisation of appraisal for the purposes of revalidation to turn it either into a tick box exercise or an unwieldy bureaucratic system, with either extreme detracting from the very medical practice that revalidation was meant to support. The tick box analogy used by our interviewees is not unique. Jerry had just already done some work around that on the introduction of consultant appraisal in 2007, which identified the frequent use of language relating to tick boxing by the consultants that were interviewed. This research discussed three perspectives on appraisal: appraisal as developmental, appraisal as a system of control, and appraisal as ritualistic, with its embodied values of efficiency and rationality. And this paper today that I'm presenting looks in more detail at the ideas of efficiency and rationality in connection with appraisal leading to revalidation. And I'm going to be using Ritzer's much contested but highly influential McDonaldization thesis to do that. So underpinning this thesis then was the classical sociological writings of Max Weber on bureaucracy and rational systems from the early 1900s. Ritzer used the McDonald's business model as a paradigm through which to critique a wide range of processes that exhibit the organisation and standardisation of activities for efficiency. By the McDonaldization of society, Ritzer means that other sectors, including tourism, work, leisure, and indeed health and education, among many, are becoming to be organised along similar lines to fast food outlets in the US, and that this is now a global phenomenon. McDonaldization has grown out of previous business models, Taylorism and Fordism would be familiar ones, but the difference with McDonaldization, which makes it pertinent to this discussion, is that it was the first model, I think, to engage with consumption as well as production. Therefore, the McDonald paradigm will enable us to discuss processes of appraisal leading to the product of revalidation, as well as the experiences of those involved. McDonaldization is characterised by four key components: efficiency, predictability, calculability, and control through non-human technology, that in combination make up the type of rational system that Max Weber back in the 1900s would have recognised. And I'm going to go through them one at a time. So efficiency first then. So this first principle is defined by Ritzer as the optimum means to a given end, key features of which are streamlining and simplifying. Efficiency in this context relies on a pre-designed process governed by organisational rules and regulations. Linking revalidation to the extant and broadly popular appraisal process obviated the need for an entirely separate system to be developed. Thus, in theory, doctors would be saved the time of undertaking a separate process and organisations the expense of implementing one. If we think of the portfolio of evidence presented for the appraiser as a product, then we can argue that the evidence to be presented has undergone a process of streamlining and simplification since the introduction of revalidation. The appraisal portfolio, like McDonald's menu, is limited, with the form and content of its component parts determined by the four domains of the GMC appraisal structure. And these are general information, keeping up to date, review of practice, and feedback on practice. The elements of the portfolio are similarly rationalised, with 6 types of supporting information that doctors are expected to provide: continuing professional development, quality improvement activity, significant events, feedback from colleagues, feedback from patients, and a review of compliments and complaints. The preference for online submission streamlines the process for appraisees, appraisers and ROs alike. Scotland, as Marie said, has a one-stop Scottish online appraisal resource, as does Wales, but in England there's much more flexibility. Another aspect of efficiency identified by RISA was putting the customers to work. For example, customers clearing their own trays in fast food outlets. In medical appraisal, it is the appraisee who has to collate the evidence for the appraisals. They're being put to work. A GMC employer liaison officer that we spoke to clearly identified the responsibility, saying, I think something that is really key and a lot of time gets overlooked is actually it's on the individual doctor. You know, they are a professional. They are a privileged profession and they have to take responsibility for their own revalidation. Well, another interviewee, sorry, that's not meant to be there. Another interviewee said, we had a go at our internal IT systems and developers having a go at making a bespoke system for us. But when you look at the cost of these things, there would certainly be a need for more server space and training and things of that nature. But we were just not geared up to do that, and the skills of the team weren't in place in order to do that. So going to an outside company seemed a much better option. If we think about this in terms of predictability, the emphasis here is on discipline, systematisation and routine. The requirement that appraisal and revalidation are undertaken regularly requires a review of what were often haphazard appraisal timetables. This is key for local doctors and outliers, but also for doctors working in secondary care, since our research identifies systemic difficulties in identifying who was often actually working in the hospital. With one appraiser for 3 years, appraisees will have continuity, and with standard portfolio components, longitudinal trends can be identified. The primary care systems manager cited the geography of Devon and Cornwall as a barrier to anything other than an electronic system. And they said, well, the beauty of this system we've chosen is that no matter where you are in the country, you can still input. You still have access to your folders and files and stuff. And so on transfer, so if somebody was going to change a performance list and go to work in a different part of the country, the company will actually facilitate the shifting between performance lists and the things of that nature. Predictability relates to the assurance that revalidation is a standardised process, expected to capture relevant and similar information across all medical fields. Just as the McDonald's burger is guaranteed to be as unappetising in one place as it is in another, patients can be ensured that their doctor is up to date and fit to practice, no matter where they happen to be practicing. The colleague and patient feedback elements have undergone a robust reliability and validity testing to ensure that the optimal number of examples are submitted. But the requirement of patient feedback as supporting evidence for revalidation is proving a concern across the sector. There are, of course, well-worn arguments about the difficulty of gathering meaningful patient feedback from anaesthetist, radiologist and pathologist, but we found more subtle concerns expressed, linked to type of patient rather than medical speciality. For example, the elderly, patients with mental health issues and or addiction problems. For one GP, the requirement that the doctor not give out the feedback forms presented challenges. She said, if somebody comes in who's intoxicated, which a lot of my patients are, or angry, or maybe has learning difficulties or something like that, then they, the receptionists, just wouldn't give them the form. I'm sure they do it like that. They wait until you're having a good day and everything is quiet and calm, and then they give out the forms. So it took them months to give out my forms. The next is calculability. Revalidation is an example, this is what Marty Chamberlain says, revalidation is an example of the internationally recognised trend that individuals and many areas of contemporary life are becoming subjected to an increasing number of calculative regimes which seek to survey and performance manage their practices in order to better economise and risk manage them. With calculability, the emphasis is on quantification rather than quality. One appraiser described the change in emphasis with the advent of revalidation. I think it's becoming that there's getting to be more regulation and it's becoming less about you personally, more about the regulations. more about having all the bits of paper, and it's no longer looking at your personal journey through those bits of paper. It's about just having those bits of paper there. In answer to the question, so do you feel that revalidation will contribute to the 3 areas of patient safety outlined in the Pathfinder pilot project, which were effectiveness of care, patient experiences and patient safety? One of the ROs that we interviewed replied us. He said, I think it will do those things, but I don't know how you measure those things. It may be the public interfaces, the way these things will be visible, but whether there will be sufficient data there to measure them. This is one of the challenges, isn't it? Looking at outcomes and interventions that what we are doing. Crucial to any discussion of calculability is the available technology and its ability to generate data and audit trails. We saw in the slide above that the system primary care in Devon and Cornwall were interested in was described as having beauty. However, in the drive to quantify, there is a risk that there will be no place for soft skills and local knowledge that were identified as important by the ROs and appraisers alike that we spoke to. The next thing is control through non-human technology. And we've kind of talked about this in connection with all the other elements so far. One interview that we witnessed took place in front of a computer screen and had a significant amount of its allotted time taken up in conversation with the system help desk, as documents had failed to upload and could not be read by the appraiser. There was a sense of mounting frustration as the appraisal process progressed, and after 20 minutes they reverted to a paper form. Several interviewees indeed expressed frustration that systems changed from one year to the next, and confidentiality was an issue for one appraisee who intimated that issues of confidentiality would impact on the content of the appraisal. Oh, crikey, isn't it? Okay, so we skip this, okay? So indeed, several of our interviewees then identified that there was an opportunity to hide information, possibly information that would have been discussed in appraisals previous to revalidation. Max Weber considered that rational systems were technically superior to all other forms of administration, but he was aware of the potentially dystopian aspect through the concept of the iron cage of rationality. Rational systems therefore inevitably spawn irrationalities as unintended consequences. Potentially, doctors could work for revalidation in the way that some teachers teach to the test. One quote from another appraisee was, some people jump through all the hoops because they have to. It doesn't mean you're a good doctor. Efficiency too can be a double-edged sword. Ritzer finds that the drive for efficiency does not always benefit the customer, who end up eating mediocre food on the run. This primary care RO alluded to the balancing act that needed to be performed by appraisers. Everything we do is on a shoestring. We're doing this horrible balancing act between effectiveness and efficiency. And finally then, sorry. Revalidation, methodization and medical appraisal. The title of this presentation might have seemed a bit flippant, but I hope to have presented a way of thinking about the relationship between revalidation and appraisal that has at least provided food for thought. Ritzer's keen to point out that there are many advantages to methodization. In the case of revalidation, it is to include a system of regulation that applies to both private and NHS doctors, a system that will ensure a predictable process that will accommodate locum doctors and outliers by assigning them an RO. And it will provide the public with the assurance that doctors, like other professionals, undergo a formal process to ensure that they are up to date and fit to practice. Ritzer's main criticism of the McDonald model is its potential to become dehumanising. He argues that the drive for efficiency means that the world may not be organised for the benefit of consumers, in our case, the doctors undergoing revalidation and ultimately their patients. But for the benefit of the organisations, we need to demonstrate efficiency to the outside world. If revalidation drives hard data collection systems, this could be at the expense of soft data. There's an attendant risk that the important pastoral element would be lost, and this would be a manifestation of the dehumanising potential of rational systems. So does revalidation represent McDonaldization of appraisal? My answer to this question would be not at present. I think we will only reach something that we might call a state of muck appraisal when there is a shift from trust in the doctor to ultimate trust in the process and the system.
And last but not least, we have Zoe Spenlock, who's going to talk about nursing midwifery.
Not quite. There's not much pressure as you come closing the show with a real tight time schedule, but I'll do my best. So I'm here to present the research I've been doing about the operationalisation of revalidation, taking a very practice-based focus in what I'm going to present. So I'll try and bring some of the things that have been discussed today into a presentation. There we go, sorry about that. So, as we've heard already, assessing the impact of regulation upon those that are being regulated is both complex and challenging. We've heard quite a lot about that today. And we also know there's a dearth of research-based knowledge exploring the implementation process and subsequent impact of regulation upon those health professional groups. Obviously, days like today and research that we've heard today will obviously add to that body of knowledge. This presentation will discuss some findings of real-time research observing the operationalisation of revalidation and explore the factors that have influenced the interpretation and construction of revalidation, posing some recommendations for the future. So, just give you a little bit of methodological background. The research was qualitative in nature, a single site, 12-month ethnographic research study in a single NHS Foundation trust. Data collection began in October 2012 to September 2013, and as I said, it was observing the operationalisation of medical revalidation within that organisation. The research was underpinned by literature reviews and informed by documentary analysis. So there were 3 main research questions and a range of personnel involved in the research, from trust management to obstetric consultants and registrars, medical management, midwifery management, and a range of midwives. The reason I took an approach within maternity services is I've got a history of being a midwife, been a midwife for 20 years, and I was particularly interested in not only the organisational operationalisation of revalidation, but also the subsequent impact that that would have within maternity services, not only upon interprofessional relationships, but subsequent care. Methods of data collection were observations, interviews, and as I've already said, documentary analysis. So I undertook 36 semi-structured interviews and spent quite a lot of time within the trust on the maternity ward and on the labour ward. You'll see that I did interview a few more midwives and doctors, and that's because, interestingly, some of the doctors avoided me when my face became the face of revalidation. They didn't particularly want to come down the corridor and they run the other way, which was interesting in itself. So, in terms of some of the research findings, I found that there were particular challenges to operationalisation, both on an organisational level, departmental level, and individual level. In some ways, these were all impacting upon each other, and I'll explain a little bit more about those. So, at organisational level, there was a distinct lack of leadership within the organisation. There was what the organisation called a revalidation implementation team that consisted of the responsible officer, a head of revalidation, and 20 appraisers within that organisation. But the team of appraisers changed quite fluidly and quite significantly over the period of time that I actually did the research. There was very little opportunity for communication across the team, no regular meetings. Any meetings that did occur were just between the responsible officer and the head of revalidation, and the main source of communication was through email. And in fact, the huge amount of responsibility of keeping the team together was devolved down to a non-medical office manager, and she was responsible for communicating with the appraisers, but also monitoring the operationalisation of revalidation and appraisal in terms of monitoring all of the paperwork. So, interestingly enough, the organisation did have a positive organisational readiness self-assessment prior to revalidation being implemented, but the head of revalidation did suggest that maybe in their naivety that they believe that they've got the infrastructure there to be able to support the introduction of revalidation, but obviously as the process materialised, they felt that those systems weren't actually there. That there was risk, performance management and quality improvement processes in place, but not in a coordinated fashion. And it was recognised that some of the data that the doctors were wanting or was required wasn't actually readily available to them to be able to have. And that was felt to be linked to the lack of IT infrastructure to be able to support the process. So the individuals were responsible for contacting individual departments to request data. So each individual department, for the doctors that were actively seeking information, were all getting individual requests for compilations of things like complaints and any involvement in risk management issues. And the head of revalidation expressed concerns that obviously due to time constraints and maybe lack of inclination, that some doctors may not actually be being proactive in approaching these organisations or these individual departments to ask for this information. And the lack of IT infrastructure, as I said, was recognised as a problem, but they were needing to put a business case forward to the Trust Board to be able to request funding to actually put the infrastructure in place that they needed. So in view of the leadership problems, the clinical governance problems and lack of IT infrastructure, there was a non-standardised appraisal process within that organisation, and as a consequence, the content of the appraisal folders and the data that was in those folders varied across individuals. And this was unfortunately reinforced by the organisational appraisal and revalidation policy, which actually at the time did say that in the absence of available data, that the appraisal and revalidation assessment should still go ahead. Interestingly enough, that has changed now, but that's what it did say at the time. So at departmental level, obviously as a consequence of lack of leadership at organisational level, there was a knock-on effect, lack of leadership at departmental level, with no support systems in place, and nobody to really champion revalidation at that departmental level, which really reinforced an individual approach rather than a collective cultural shift, which is, I think what was aspired to in terms of the introduction of revalidation. There was also a lack of human resource investment. Both appraisers and the appraisees were concerned that there was just a lack of time to be able to undertake the requirements of the changes with relation to appraisal and revalidation. And this obviously affected appraisal performance. The appraisers had very different backgrounds and very different training in relation to undertaking appraisal, and very rarely had the opportunity to meet and share best practice, which obviously then reinforced the issue of appraisals being very different and being undertaken very differently across the departments. So at an individual level, reflecting back on some of the issues that I just spoke about there, it's not unrealistic to think that there was slight ambivalence towards the policy process. All of the professionals that I spoke to were unanimously in agreement that the introduction of something like revalidation that was aimed to improve patient safety was undoubtedly a good idea to introduce. But they've got reservations about whether the systems that were currently in place had got the ability to improve patient safety due to some of the problems that I previously identified. and the policy process had been interpreted as a tick box exercise with minimal impact upon their professional fitness to practice or indeed on patient care. So you can see also that that would have had an impact on individual engagement. There was difference in engagement across the professionals, from a no news is good news approach down to individuals cancelling clinics and cancelling theatre lists to actually allocate time to be able to undertake this process, which obviously then when you reflect back upon the impact upon patient care, you can make assumptions yourself whether that is a positive or negative impact upon patients. And individuals had also got frustrations as to what constituted fitness to practice data and performance management data. They felt that a lot of the data that was available to them was just proving that they were able to do the job. How many people that they were seeing in clinic, how many clinics they did, how many people were under their care, rather than actually data that was related to outcomes data, return to theatre, any readmissions. That data wasn't available to them unless they actually was able to undertake individual notes audits, which is essentially probably where the cancelling of clinics and cancelling of theatre lists came from, to free the time for them to be able to actually do that. So looking at some of the implications of these research findings, you can see that individuals generally failed to identify with the aims and purpose of revalidation and viewed it as a bureaucratic form of extra regulation rather than a professional imperative to demonstrate the fitness to practice. And rather than being viewed as a cultural change, you've got the first respondent here saying it's an aim to eliminate doctors. We think that's probably a little bit of a drastic claim, but that's what one of them did say. And that revalidation is a necessary evil, so jumping through hoops to complete the paperwork activity, which is probably due to within that organisation some of the issues that were previously identified. But being viewed as a paperwork activity rather than a reliable fitness to practice assessment, it wasn't generally viewed as a process that was fit for purpose. So if I've got this third respondent, revalidation will not pick up a shipment. But we all know that was never the aim of revalidation, but that's how it had been interpreted by these individuals. So revalidation had inevitably been constructed within this organisation, because of the perception of a bureaucratic regulatory process, and probably influenced by what they'd observed and experienced through some of the challenges that I'd identified at the 3 different levels. So, due to the organisation being unable to support robust appraisal processes, there's been a perception that little had changed with previous processes. So, that this first respondent said it's just a nice new name for something that we've been doing already. They've not particularly appreciated that the process had actually changed. And individuals are recognising the limitations of the current provision of data available to support revalidation. So the second respondent here is saying that people are choosing or potentially able to choose what data they present to their appraiser. And the third respondent there saying that actually the core data that we need to prove that fit to practice just isn't there, and bravely suggested that appraisers are actually signing people off without seeing that information. So there's a perception that there's minimal impact upon individual practices and minimal impact on patient safety. So this is a small-scale study, but nonetheless I think provides valuable insight into organisational operationalisation of revalidation, and demonstrates that the regulation of individual registrants and the impact of that regulation upon those registrants is directly influenced by the organisation in which they practice. And for that reason, this really must be taken into consideration when considering regulatory processes. Looking at the fact that effective leadership, robust clinical governance, investment and standardised processes are required. It sounds absolutely obvious, but they just weren't present within this organisation. So I think if regulators are to realise the intended behavioural impact of regulation upon registrants, the regulators require a stronger link with organisations in order to identify and overcome some of the barriers that I've discussed, and organisations must work together with regulators to use uniformity of policy implementation. It's interesting talking about bringing the regulatory bodies together and trying to make them work together, and I think probably in this instance that would probably definitely help in this organisation. Thank you.
So we're under strict instructions to be out of here by 4 o'clock. So are there any quick questions for any of our presenters if they want to come up? Try and bring up Harry. Are there any questions? Yeah, Bill.
Thank you. I have a question for Marie. Marie, your 90 doctors, it's not a random selection, is it?
Well,
could you say a little bit more about how you've been selected and how much reliance, because it's obviously a very small number of people, but it's going to be a core part of your data. And I think then you're going to sub-select people for interviews, aren't you?
The approach is going to be that at the end of the survey, we're going to ask if doctors would consider taking part in further research activities with us. So there'll be a self-selecting sample in that way. We have no way of knowing before we send out the survey how many people are actually going to kind of say yes, we'd like to get involved. So to some extent it does depend on the response. We hope that we will get a lot more than 90. We hope we'll get a response to the survey, and we hope out of that we'll get more than 90. And within that then we will try to select doctors from a range of kind of demographic backgrounds and different protected characteristics, as that's a key focus of the research, but also within different settings and different job roles, working in different types of healthcare provider. So there is, the intention is to achieve a good mix of different perspectives and different experiences within that sample, but to some extent it will be driven by kind of who agrees to take part.
Any more questions? Final speaker for today.
First of all, just to reassure those of you who are suffering from acute anxiety, that the coach will not actually leave until we've got on it. And I promise I'll be last on. But I'm not going to keep you. I just want to say thank you. I think thank you to everyone who's participated. It's been terrifically interesting day today and evening yesterday, those of us who were there. There's been great diversity of ideas, both theoretical and practical. It seems to me there's been a strong theme of the interrelationship of human behaviour and regulation that's run through a lot of what we've been hearing. It reminds me always of my experience when I was an advisor in the Department of Health, and I always be meeting with my civil service colleagues, and they'd say to me, "Yes, Harry, that's a really good idea. We can see it would work in practice, but would it work in theory?" So I think that whole issue of bringing the two together is really critical. I'd like to thank Jerry and Warwick Business School for being our collaborators. I'd very much like to thank my own fantastic team, Douglas in particular, who's put this together, but Jerome, who's been working with us recently, seconded from the General Pharmaceutical Council, and Dinah and Amy as well, and all of you, and safe home, and I promise you the coach is still there.